Hello and welcome to today's internal medicine webinar. My name is Lydia Morgan and I am commercial manager here at Virtual Veterinary Specialists. At VVS, we're on a mission to increase the collaboration between first opinion vets and specialists. Our goal is to help you to approach every case with confidence. We empower vets to work together in real time alongside our specialists, allowing you to deliver referral level care to your patients in your own practice. See our specialists as an extension of your own clinical team. Our virtual support includes our brilliant VVS internal medicine service. You can work together with Dr. Florence Vessieres and her fellow internal medicine specialist colleagues through our specialist advice calls, reports, and more. Discuss your patients and how they've presented, the investigations so far, and collaborate together to continue to successfully manage your cases in-house. By submitting the patient history in advance, you receive relevant and valuable support, and you won't be frustrated playing telephone tennis. These calls are scheduled at a time which is convenient for you. Today, Florence will be discussing the importance of nutrition in critically ill patients, a fascinating topic and something which I'm sure we'll have some valuable takeaways from. So it's my great pleasure to introduce Florence to you. Florence graduated from the University of Toulouse in France in 2013. She completed her residency in internal medicine at Anderson Moores and became an American and European diplomat in 2018. As well as working as a referral clinician and telemedicine consultant, she's worked in the pet food industry in expert support roles for various departments. Florence is passionate about education and her clinical interests are acute medicine as well as gastrointestinal and renal diseases. We're so lucky to have Florence on the VVS team, bringing her interest in medicine and nutrition, as well as her care and compassion to the role. If you have any questions as we go through the webinar, please add them to the chat box, and we'll finish up the presentation with a question and answer session at the end. So with that, I'll hand over to Florence for today's talk. Thank you, Florence.
Hi everyone, I hope you can all hear me and see me. Welcome to this talk, which is about the importance of nutrition in critically ill patients. I hope that through the talk you can grab some information that you can directly apply to your patients, because that's a topic that, whether we realize it or not, really is important, of course, but also affects all of our patients. So we're not only going to talk about extremely ill patients that are hospitalized in ICU. We are going to talk about any sick patient that you may see in your practice and the importance of nutrition for them. So stay tuned. I hope you'll enjoy. Before we start, I don't have any major conflict of interest. As Lydia said, I used to work for Royal Canin for 5 years, but I'm not a Royal Canin associate anymore. Now I work only as an internal medicine specialist, and I have clinical activity in Switzerland and also work as a consultant for VIN and VVS. So we are going to start today our discussion with one big statement, and that is that most hospitalized pets are undernourished. And I've written most in red because you're going to see that the data we have is actually quite shocking. Us as vets and veterinary nurses, we're not very good at feeding our hospitalized pets. When I say undernutrition or undernourished, I mean that the pet is not covering their RER, so they are not covering their resting energy requirement, which is the lowest amount of energy, of calories that you need in a day just to lay there, do nothing, just thermoregulate and have not many activity actually. So that's just the RER. And if you're undernourished, that means that you're not even covering this RER. So there was a paper published in 2018, and it was a prospective study that was published by mainly nutritionists, and they looked at 500 hospitalized dogs, so dogs that stayed for more than 24 hours in the hospital, and it was a veterinary teaching hospital, so they had enough staff, and they were trying to really do the things by the book. So we could hope that in this case, nourished pets were not very numerous. But that's the first poll. According to what you think or what you've experienced, what was the percentage of dogs that in this hospital consumed less than 25% of their RER? You're going to have a little box to vote now. Was it 45%, 65, 75, or 85%? So how many of them were not covering 25% of their RER? I'll give you maybe 10, 15 seconds, and then we're going to see what you think. So how many were we're not even covering 25% of their RER? Okay, I think we can see the result. Okay, so the majority voted 65%, and then some of you 75%, and some of you 85%. So, suspense, I'm going to show you the answer. The answer is 85%, unfortunately. So the exact number, I think, was 84. Yeah. So 84% of dogs in that hospital consumed less than 25% of their RER. And what's even worse is that only 3% of the dog met their RER. So even if you're a dog hospitalized in a big veterinary teaching hospital with a nutrition team and a medicine team and a lot of nurses and everyone is there to support, only 3% of the dogs met their RER. That's where the statement of most hospitalized pets are undernourished comes from. So we really have to work on that. Through this lecture, we're going to talk about why does it matter that we don't feed these pets as much as we should, what to do about it, and then we're going to have a little focus on assisted feeding as well. So why does it matter? Because undernutrition is associated with a lot of negative effects on the body. The first one is altered metabolism. So if you are a healthy pet and for any reason you have to starve, so that can be a cat that is closed in a cave for 2 days, it's a healthy cat, it's just 2 days, he's not sick, or that can be a dog that you starve overnight or for 24 hours to do a procedure. That's a healthy starvation. So a healthy body will be able to first use their blood glucose. Then if they still don't have any calorie intake, they will go into their glycogen reserve in their liver. And then if they still don't have any calorie at that point, once they've exhausted the glycogen reserve, they will use their fat. But if you're sick animal, if you're stressed, if you have an impaired metabolism, if you have any impairment in your body really that makes you sick and in an inflamed status, you will have a different metabolism. You will first use your blood glucose and then your glycogen reserve as a healthy dog, but then you will catabolize your muscle and proteins directly. You won't go through the fat processing. You will directly catabolize muscle and proteins, and that's catabolic state is very detrimental. So because of this altered metabolism, starving a sick pet is quite detrimental. Impaired immunity. There was an old study that was published in the 70s that showed that if you starve cats, within 7 days, they have a significant reduction in their white blood cell count, mainly the lymphocytes, and they also have lower amount of immunoglobulin, and also the function of this immunoglobulin is affected. And then they were feeding this cat again, and they noticed that despite 7 days of nutrition again, these numbers were not back to normal. So starvation and undernourishment in cat has a strong effect on their immune system. Gastrointestinal impairment and bacterial translocation. Probably you've all heard of the fact that enterocytes, they get their energy directly from the food and only from the food, so from the GI tract lumen. So when a pet is starved and they don't get enough nutrition, the enterocytes can atrophy, and that would weaken the GI barrier. So for example, in this study that was published in 2003, if you look at 30 puppies that had parvovirus, they shown that the one that you feed earlier had a reduction of bacterial and endotoxin translocation versus the one you fed only when their vomiting had stopped. So it seemed that early nutrition can help really protect this GI barrier and fight against bacterial translocation. And finally, poor outcome. So that's known for sure in human medicine, and now we have more and more evidence, especially in dogs, that early voluntary or assisted feeding, enteral feeding, is associated with better outcome for different diseases. So I've just written some examples there. When you have puppies with parvo enteritis, they clinically improve earlier if you feed them earlier. For dogs with septic peritonitis, they are hospitalized for a shorter duration if you feed them earlier. Dogs with acute pancreatitis will eat earlier if you provide assisted feeding earlier. So it stimulates the appetite and the GI tract motility. And then for hospitalized dog in general, and that's the paper published in 2001 by Remy Yard, you have overall significantly higher chances of survival and of discharge if you provide assisted feeding early in time. So overall, nutrition is now clearly recognized as fundamental in the management of critically ill patients. And when I say fundamental, it's as important as fluids, analgesia. It's not a side, is really part of the treatment. And this is true in humans and in pets. And just to show you something else that is interesting, in this paper published in 2019, that's a human paper, the European Society for Clinical Nutrition has published some guidelines, and their first statement is actually that every critically ill patient staying for more than 48 hours in the ICU should be considered at risk for malnutrition. So malnutrition is undernutrition, and undernutrition for pets could be used similarly. Malnutrition can include also overnutrition, but in our case, we won't use that. So here, what they say is basically that even in human, after 2 days in hospital, you are at risk of undernutrition, like our pets. So that's something we really need to focus on. So what to do about that now that hopefully I've convinced you that it matters to feed these pets to improve their outcome. So what to do about them? So the first thing we should ask ourselves is actually why are they undernourished? What is happening? And this paper published in 2001 specifically looked at what were the reasons behind the fact that these dogs were not receiving enough calories in hospital. So the objective was actually to, again, estimate how many patients were in negative energy balance. That means they were not covering their ARIA. And they looked at 276 dogs in referral hospitals in the States. They found, this time was a bit better than the other one, they found that positive energy balance, so meaning that the dog was fed enough to cover their ARIA, was achieved in 27% of the cases. So better than the other one, but still it means that there is only 1/4 of the pets that were receiving their ARIA. So that means that 3/4 of them were undernourished. So it's still quite, it's not that good actually. And why were dogs undernourished? So again, a little poll to see what you think. What's the percentage of dogs that you think were undernourished because of poorly written feeding instructions? Less than 5%, 10%, 20%, 30%. That means human error. Lack of communication, or it's not well written, or no one knew that this dog needed to be fed, or really purely human error. Less than 5, 10, 20, or 30. I'll give you 10 seconds. Okay, let's see what you think. Okay, so most of you think that 30% of dogs were not well undernourished because of poor feeding instruction. It's not far. It's actually 20%. So it's not that bad, but it's still very bad. 1 in 5 dogs didn't receive enough food simply because they were not. It wasn't written on their kennel sheets that they needed to be fed. And that's something that really is maybe not easy to improve, but something that we should take ownership to resolve in our practice. It may not be easy because obviously we are busy. A lot of people are dealing with different dogs, lack of communication, lack of time. But that shows you that already by just improving communication, you can remove 20% of undernutrition. And so 22% had poorly written feeding orders out of these dogs that had energy balance, negative energy balance. So as I said, clinicians and nurses are responsible to work on that. So clear and accurate communication and feeding instructions are paramount, obviously, for that. 34% of these dogs had ordered to have food withheld. So it may be that that's actually correct, and these dogs were not fed, and it was appropriate, and they shouldn't have been fed, and that's okay. But ask yourself, is it really necessary? For example, it's no longer recommended to stuff pets with GI signs, like a dog with acute pancreatitis, or a dog recovering, or a cat from septic peritonitis, or they had enterectomy. If they are awake enough to eat, they should be fed, unless obviously you're starving them prior to surgery. But none of these patients should be starved when they are recovering. So really ask yourself, is it really necessary to starve these patients? So 22% poorly written feeding orders, 34% they needed to have food withheld. And most of the cases, 44% of them, were in negative energy balance because they were refusing to eat the food, either a little bit or they were totally anorexic. And this is where we can make also a difference. So I think we can make a difference on these 3 points, but this is when really you would need probably to be the leader of some change in how you practice every day, and where you could make a difference for these patients. So that's what we are going to think about now. Think about all your patients. So very sick cats that we don't really know what is happening with them. They are anorexic, we are still doing investigations. Or the dog that came with RTA, or the dog that got bitten by a snake, that's the one in the middle there, that you think will get better, but is still not doing very well. Or it can be really a pancreatitis, that beagle had pancreatitis, or a dog that comes for a medical problem and needs to stay hospitalized for a few days. Think about all of them, very sick, not very sick, just a hospitalized patient. Do you think that you have an accurate and detailed record of their daily food intake? How much they eat today? How much was offered, and what the percentage of that was eaten? Because if not, then it becomes very hard to identify this undernourished pet. And is there an appropriate feeding plan? So if you answer, I don't have an appropriate feeding plan, and it's quite complicated for us to do it in the practice, we don't have the sheets, then I'll encourage you to have a look at this one. So you can have your own one, that's not an issue at all. But if you don't have an own one, you don't need to reinvent the wheel. You can just steal with pride the one from WSAVA, because it was made to be shared. So if you go on the WSAVA website, this is a PDF version, so anyone can download it. And it's a great chart to calculate how much food you want the dog to be offered, and how much food was eaten. And it even has a very nice calculation tool at the bottom, so you can calculate the area, calculate how many grams of food you need to give, how many grams of food you need to give every day. So I really encourage you to download and print that for your hospitalized patients. I have the feeling that no pet should have a kennel chart that doesn't include nutrition guidelines. So pretty much every hospitalized pet should really have that on their cage. And then at the back of this sheet, you have nutrition monitoring charts. So you can write how much was offered, how much was eaten, what type of food was offered. So that's really a great tool if you don't have one in your practice at the moment. So look at all your patients. Do you have accurate and detailed record of food intake? Is there a feeding instruction plan? Once you have done this, it should be easier for you to detect if your patient was able to cover at least 80% of their RER. So when I used to work at Anderson Moores in the morning rounds, or when we're looking at our patients, that was part of our assessment, looking at the past 24 hours and asking ourselves, were 80% of their RER covered, yes or no? I've written here for your information how to calculate RER. So there is a simple version at the bottom for pets between 2 and 30 kilos, and otherwise the more precise one is the one at the top. So that's just for your record. So are they able to cover at least 80% of their RER? If yes, great. It's okay if it's not 100%, 80 is totally fine. If not, then that should raise an alarm bell. That means that you need to actively evaluate and manage this patient. So it's actually now accepted that you should have a nutritional intervention, and that's in most of the cases means placing a feeding tube, if there is hyporexia for more than, let's say, 3 to 5 days. So when I say evaluate them actively, it's because there may be an action that is needed if you find that they haven't eaten 80%. We know that detrimental metabolic consequences are observed after only 3 days of starvation or hyporexia, so we need to act fast. And the enteral route is the route of choice. So I'm not going to talk today about parenteral nutrition because enteral is the safest, obviously. It's the most convenient. Most of the practices can provide it, which is not the case of parenteral. And there are not many actually indications of parenteral nutrition. And I believe that these cases should probably be hospitalized in ICU in a larger hospital. During my whole residency for 3 years, we've managed a lot of very sick patients, and not once we had to use parenteral nutrition. So I think that enteral route works for most of the cases. The enteral route is the most physiological route for nutrition. As we were discussing, it's feeding the gut, so actually prevents villi atrophy and risk of bacterial translocation. So my patient is not covering 80% of their RER. What do I do? Of course, you have to stabilize them for 12, 24 hours. I'm not saying that you should place a tube straight away in this dog that is collapsed and has profuse bleeding because of rodenticide intoxication. No, of course, stabilize them. Take 1 day to have them cardiovascularly stable, correct dehydration, hypovolemia, electrolyte problem, hypoglycemia. Yeah, they need to be stable, of course. Manage the pain, manage the nausea if indicated. Perhaps consider appetite stimulants. I'm not really a big fan of appetite stimulant in sick patients. I think it's a great tool for cats, for example, with CKD, or dogs that have chronic enteropathy that can have sometimes a bit of anorexia. But sick patients, usually if they don't eat, it's because they have a problem, and that problem giving appetite stimulant is not going to be enough to balance that and get rid of that problem. But you can consider appetite stimulants if you want for 12 to 24 hours. If they don't work after 24 hours, then forget about it and consider assisted feeding. So if a patient covers less than 80% of their RER for 3 days, despite the above efforts, then it's really time to intervene and take an active approach and consider assisted feeding with a feeding tube. There were a couple of papers that were published. One was published in 2020 by Dan Chan from the RVC, who is a specialist in nutrition and in ECC. So that's quite a nice viewpoint that he has on these patients. And he's established a list of risk factors to help you making a decision to place a feeding tube. So his recommendation is that as soon as 2 high-risk factors are identified, we should place a feeding tube. And these are the risk factors. So as we said, eating less than 80% for more than 5 days, not eating at all for more than 3 days, having weight loss, severe vomiting, diarrhea, being thin, hypoalbuminemia, expected course of illness above 3 days, hepatic lipidosis, and if you have a puppy or a kitten, that's also important. If you identify 2 of these, you should seriously consider placing a feeding tube. So you have made the decision that this patient needs assisted enteral feeding based on the previous discussion. So now what to do, how to do it. There are 2 main tubes that can be placed in our practices, and you're probably familiar with both of them. One is the nasoesophageal or nasogastric tube, and one is the esophagostomy tube. To tell you the truth, I have very strong preference for the esophagostomy tube because I find that pets are doing much better with them. And it requires not that much, like the anesthesia is usually quite short, it's quite easy to place, and then you can keep them for so much longer, and you can really send the dog or the cat home with them. So I really prefer esophagostomy tube, but both of them have their utility. So as you know, the nasoesophageal tube is mainly for less than 5 days, whereas the esophagostomy tube, you can leave it for as long as you want. I've had cases of cats with CKD that kept them for more than 6 months. Both of them are relatively inexpensive. Both of them are relatively easy to place. The NO tube would be placed under sedation. The O tube will be placed under anesthesia, but usually it's an anesthesia less than 20 minutes. The great thing with the O tube is that you can use pretty much any diet that would fit in the tube, whereas the NO tube, you have to use really liquid diets. So both of them have different indications. You may have your favorite one, but just to let you know that the O tubes, really, if the pet is sick, place an O tube, it will be so much better. The cats, they hate having NO tubes, and cats with O tubes do so well. I would really encourage you to consider placing more O tubes. So for example, when would I place an NO tube? So not very often, as you understood, but I would place it for a Labrador, for example, who underwent an X-lab for a foreign body, and I'm not really sure if he's going to eat on recovery. I know that he's a Labrador, so probably he's going to eat whatever happens. But I also know that the surgery was quite hard. Maybe there was an enterectomy, so I'm not that sure. And I think I really want to feed his gut. So I'm going to place, before he wakes up, an NO tube, because I'm hoping to remove it very soon, but it gives me a sort of safety net in case it doesn't eat within the next 24 hours. I would also use NO tube, and as the main reason why I will use it, when I think that the patient would need nutrition on the longer term, but they are too sick at the moment to be anesthetized. For example, a very sick cat with hepatic lipidosis, hard to stabilize, electrolytes all over the place, neurological. I really don't want to anesthetize it straight away. Or maybe it's a cat that has coagulopathy because of his hepatic lipidosis. I could place an NO tube, keep it for a few days, and then when the cat is more stable, you could place an O tube in a second time. Or small puppy with parvo, again, I'm worried of anesthetizing a tiny puppy that is hypoglycemic. Just place an NO tube and hopefully he'll start eating soon. But I would use O tube for pretty much any other case that needs assisted feeding. So for example, acute severe pancreatitis, they're not going to eat in 2 days. They're going to feel nauseous. If they have this NO tube in their nose, they're not going to like it. It's going to be hard. I just place an O tube, and I know that they will feel better as soon as we provide food. And I can also choose a diet that is low in fat if I have an O tube. Acute kidney injury, for example, leptospirosis, I know they're going to be hospitalized for 1 week or even sometimes 2 weeks. They're not going to eat. They're going to feel miserable. I need to feed them. I just place an O tube. And then, as I mentioned above, patients that may have hepatic lipidosis that are stabilized now, in that case, you could place the O tube. So that's all just some examples. There are some relative contraindications for feeding tube placement, especially for O tube placement. If they have uncontrolled coagulopathy, try and solve the coagulopathy before. It's not absolutely contraindicated. For example, in dogs that have thrombocytopenia, I have placed O tubes. Obviously, you discuss the risks with the patients, but sometimes they just don't eat and they have this thrombocytopenia that lasts for a very long time, and you just need to help them, and you take the risk and you use cautery, and you have a surgeon with you to assist you if needed. Marked electrolytes abnormalities, especially the potassium. If you have disturbance of the potassium, you may have GI stasis. They may feel bad. It may contraindicate the anesthesia. So fix that before you anesthetize them. Hypotension, hypovolemia, again, we want to fix that first. And if there is severe esophageal dysfunction, lack of gag reflex, these are cases where perhaps parenteral nutrition would be better, because if you just feed them and the food just stays there in the esophagus, it's not going to go well, and there is an increased risk of aspiration pneumonia. So the decision has been made to start assisted enteral feeding. You've chosen the tube you want to place, and now what? So what do you think you're going to use for this patient? What diet do you think is recommended for critically ill patients? Would you choose to feed them a bland diet, so you tempt them with chicken and rice, or you try and do a soup with chicken and rice, or just a bland diet? Or do you try and feed them with a high fiber diet? Or do you try and feed them with high fat, high protein diet? What do you think is best for critically ill patients? That's the poll number 3. I'll give you again 10 seconds. Okay, let's see. What are we going to feed these cats and dogs? Yes, so some of you think bland diet, and the majority of you think high fat, high protein diet. Okay, the good thing is that no one said high fiber, which was wrong. But so what we need to feed them is, oh, just a second, it seems to have frozen. Yeah, I'm here. So high fat, high protein diet is the correct answer. Why? Because, as we said, critically ill patients have this altered metabolism. They are going to straight away tap into their muscle and protein reserve instead of using their fat. And that's detrimental to them. They are going to be in this catabolic state. So you want to feed them high protein so that actually they can use the protein that they are ingesting rather than their own muscle. So you want high protein. They're also at high risk of weight loss. You want to provide high calorie, and that's achieved by providing a high fat diet. So you want to provide high protein and high fat. You want it to be highly digestible and easy digestible. So you don't want to have any fibers there because the fibers may make it harder to digest. And if you have high fibers in your diet, you can't have high calories. So it's important to have low fiber diet, low residue. Of course, if the patient has hepatic encephalopathy or CKD and you want to limit the protein intake, then obviously adjust that. Or if the patient has pancreatitis, again, adjust that. But otherwise, if there isn't something that contraindicates fat and or protein, feed them high fat, high protein. What about bland diets? So some of you have mentioned that they would feed bland diets. So I think that we probably need to try and come out of this era of bland diet. I don't know what you call the bland diet, but there is so much money and effort and time that is spent into creating diets now with a lot of nutritionists all around the world and very advanced techniques to create diets that are extremely easy to digest while providing all the nutrients that you need to really recover. I think it's a shame to feed a bland diet such as chicken and rice or of white fish and rice. Or it's a shame to feed that if we can actually feed a highly technical diet. So yes, you're going to say that I used to work for Royal Canin. That's true. But actually working for Royal Canin, and I know that other brands that are called scientific brands, such as Hills or Purina, also put so much effort into research to provide a highly technical diet that all the effort that is put there is, I think, incomparable to feeding a bland diet. And I'm just going to give you one example. So I would say that it's not recommended to feed a bland diet. The main reason is that it could really easily lead to nutritional imbalance and nutrient deficiency. So if we take the example of B vitamins, they play an essential role in the metabolism and of the fat and of the protein. So when you have these sick patients that have altered metabolism, you want to have a good amount of B vitamin to help them in their metabolism. Two of these B vitamins are water soluble, so thiamine and riboflavin, and they are stored minimally. That means that you use what you get in your diet. So the diet is your primary source of these. So if you're starving, then you're probably depleted in these two particular B vitamins, which could impact your metabolism. I've written here the FEDIAF recommendation for the thiamine and riboflavin in milligram per 100 gram when you feed a dog. And I've written at the bottom the address if you want to see other recommendations. And I've written on the right how much chicken breast provides. So that's much, much lower than what is recommended. And that's just one example. So yes, it's better to eat chicken breast than nothing, of course. But I think that we've reached a point now where we have diets that provide everything we need, very high calorie, very easy to digest, that won't cause any nutrition deficiency. So please try and avoid bland diet and try and feed this what they call critical diet. Or I'm going to give you some examples now. So yeah, Royal Canin, they have an ICU range, which is great because you have the recovery liquid, which is easy to calculate because it's 1 kilocalorie per milliliter. It fits in any tube. It's okay for puppies and for kittens, for cats and dogs. So that's your go-to diet. But you also have other diets that have lower fat, for example, the GI low fat, or lower protein, for example, the renal liquid for cat and dog. So you can adjust, but you don't have to feed that. For example, Purina has also their convalescence diet that is great. It's not liquid, so you would have to mix it with a bit of water, but again, highly digestible, high calorie, provides all the nutrients you need. Or Hills AD, for example, ID is also a good one. So I really think that when these patients are sick, this is the time of their life where they deserve the most advanced nutrition. And these diets, I'm confident, provides that, whereas a bland diet, I'm not sure would give them the best chance to have the best recovery possible. I hope I've convinced you. And once again, I don't work for any of these brands anymore, so that's just my personal conviction as a medic. So the decision has been made to start enteral feeding. We've discussed what you want to feed, how much, how fast. Usually people are quite confident with that, but we say to start at 25-33% of the requirement and increase over 3 to 5 days, depending on how long the anorexia has been. That's really a flexible approach. What the risk is, so it's, yeah, you can have a refeeding syndrome if the cat has been locked in a cave in a basement, for 2 months. Yes, refeeding syndrome is possible, but it's extremely uncommon. In most of our patients, what we are going to see as a complication is more nausea, vomiting, ileus, and that's why we start low. The goal is to have 100% of your area covered over 3, 5, 7 days. There is no rush. We just want them to be comfortable. So we increase as fast as possible, but as slow as needed. So what can go wrong? I hear you ask. First, and that's a big barrier actually, the owners don't want it. So you've mentioned the feeding tube, but they're just not interested. I've noticed with my patients that talking about feeding tube can be a bit shocking for the owners, whether it is because it brings back memories of someone in their family or friend that they've known that had the feeding tube and it's bad memory, or they feel like it's maybe is going to affect the quality of life of their pet, and they think it's too much for their pet, or there can be a little bit of a mental block there. I always say to the owners when that happens, if it feels like they have a mental blockage, I always say to them that if they were to visit a hospitalization ward in a referral hospital, probably 50% of more of the patients would have a feeding tube placed in. It's extremely, extremely common to need that. Nowadays, we know how to place them safely. It's not something extremely unusual. It's not something very invasive. It's something that is done extremely frequently. When I was working again at Anderson Moore, there wasn't one day where we were not placing a feeding tube. So we have to remove a bit this sort of stigma associated with feeding tube. It is something that can be done easily and happens often. Some communication tips. So I always have the conversation when it's a sick patient on day one, when I admit the case. I presented actually when I discussed the estimate, the costs. I discuss what investigations may be needed, what treatment may be needed, and as part of the treatment, feeding tube placement may be required. Always use a package for the price. So I would hate for you to be stuck in a position where the owner say, okay, we can afford the feeding tube, but we can't afford to take a radiograph, because that is absolutely forbidden. We can't place a feeding tube without checking with the X-ray. So it has to be a package. Either we place a feeding tube, we do it well, and it includes feeding the appropriate diet, handling the tube with the appropriate care, and taking a radiograph, or we don't place it. Radiograph is not an option. We talk about this a bit more later. Okay, so that's when the case is admitted on day one. You discuss that, and you discuss the fact that it's a package and the patient may need it. Day two, they're still not eating. Okay, you may consider appetite stimulant, as we said, but you discuss again with the owners, look, it has been too long now, this anorexia. I am trying appetite stimulant for 12 to 24 hours. If it doesn't work, we will need a feeding tube. So you prepare them again, you add another layer of preparation. Day three, since the beginning, you've been talking about this feeding tube. Now it is the time to place it. And I find that with this gradual approach, mentioning it from day one, they have time to mature this idea, and it's more accepted when you manage it like this. So that was the first thing that can go wrong. Obviously, there are other things that can go wrong. There are complications possible. So I'm just going to touch on this now. So that's why I was mentioning the radiograph. Always check the radiograph. There are more and more case reports now. This one is about nasogastric feeding tube that were misplaced in the tracheobronchial tree. So this patient had either didn't have X-rays or had X-rays, but they didn't have two orthogonal views, they just had one, or a vet checked and thought it was okay, but actually it wasn't. But radiograph was often a big problem in these patients, and a good part of them died, unfortunately. So it is a procedure that is usually quite safe and straightforward if we do it with all the verification that are needed. So always take orthogonal views. I can share my experience. I've placed one day a feeding tube. We were running around. There were many cases. The ward was full. I had consultations coming. Placed a feeding tube, took an X-ray, looked at it. I said, yes, it's fine. You know how you look at an X-ray between two consultations in the corridor. Up, yeah, it's fine. It's okay. You can start feeding the patient. And then thankfully, a specialist in imaging reviewed, because it was the protocol, reviewed the X-ray a bit later and then called me and said to me, I hope you haven't fed this patient because you're in the trachea. And we had put some water and the patient didn't cough. We had tried to suck and it felt like there was vacuum. So I was quite convinced all was well. So I'm going to advise you to always have these radiographs reviewed by two vets. Look at it quickly. It's okay, but at least have two of you looking at it quickly, because it can be fatal really to misplace that. And I've done it. I've misplaced it and I thought it was okay and it wasn't okay. And if that second person wouldn't have reviewed it, probably we would have killed the dog. So it is extremely important to have it reviewed by two vets. If you're unsure, you can also use a capnograph to see if there is CO2 that comes out. If that's the case, then you're obviously in the lungs. And some people have started also using a bit of diluted iohexol, a contrast product, tiny bit, and then it becomes quite clear actually if that's going in the lungs or if that's going in the stomach. That are some tips. Other complications, so that's a nice paper that was published on 250 cats that had an O-tube placed that was done in the UK. What they found is that most of the time things go well. The worst thing that can happen is that either the cat removes the tube or there is a little stomach infection, but that's really easy to manage. Worst case scenario, you remove the tube, but at least you've provided nutrition for a few days. And usually when you remove the tube, there is no need for antibiotics. You just clean it locally and it's fine. If really it seems infected and there is an abscess, which I haven't seen, but I know can happen, then you can do a culture and treat appropriately. But I haven't seen any severe complication, even of stomach site infection. There is an increased risk of infection for chemo patients and for patients that are on steroids, understandably. There isn't an increased risk of infection, even if they keep the tube for a long period of time or if they are discharged home with the tube. So that's quite positive. It means that we don't increase the risk of complication by sending these pets home with these tubes. There is another resource I wanted to share with you, which is amazing for the placement of these feeding tubes for you, for your team, but also for the pet owners, because it also helps them about how to look after a cat that has an O-tube. So if you want to read about it, there is this great guideline that was published in 2022 by ISFM about the anorexic cat, so management of the inappetent hospitalized cat. Most of what is said there is applicable to dogs. But the extra resource they have done, which is amazing, is that they have 3 YouTube videos. So I've put them there so that you have their title. It's on their YouTube channel, on the iCat Care YouTube channel. So that's made by Royal Canin and ISFM. And these videos are amazing because they show you really step by step how to place these tubes, and also step by step how to use these tubes. So you can also send the link to a pet owner in advance of placing the tube. That's the one at the bottom, where you can see how they will be able to care at home for their cat with an O-tube placed. And that shows them that it's not that complicated, and it may look more achievable for them if they see a video in advance. So I would really encourage you to use these resources. They are free of charge. You can share them. The 2 at the top are for vet professionals, and the 1 at the bottom are for anyone who cares for a cat. Okay, now the good news, what can go right if you place the feeding tube? For the patient, you'll finally be able to feed this patient and feed their gut, and you will improve their outcome as we've seen. You will accelerate their recovery, and you can send them home. So that's actually great for the patient. For you as a vet, you know that you've practiced gold standard medicine and you're really holistically supporting these pets. So that includes treatment and nutrition. And also, obviously, you are going to charge for it. So that gives you some procedural fees. And for the owners, you can shorten the hospitalization time, because even if they don't eat that well, then they can take their pet back home. It improves the outcome of their pet, which ultimately is what they want. And also medication becomes easier. I haven't mentioned that before, but specifically with O-tube in cats, you really can damage the bond between the cat and their carer if you have to give them 5 pills a day. That's really not nice at all. With these O-tubes, people can finally breathe and they don't have the stress of making the cat dyspneic because they have to pill them, and it's really hard sometimes on the owner. So I find that this is also a very nice thing, is that it helps them medicate their patients. When to stop? So that will be our last poll. Imagine you've placed a feeding tube, it's all well, the patient is getting better thanks to the nutrition, partially thanks to the nutrition that you're providing. When do you think you can remove the O-tube? Is it when they cover 80% of their RER for one day, or 100% of their RER for one day, or 80% for 1 week, or 100% for 1 week? What is your threshold for that? I'll give you again 10 seconds. Let's see when you would remove that. When the patient covers 80% of the RER for 1 week. Yeah, I think it's correct. Maybe it's frozen again. Yeah, my answer is ideally 100% of the RER for 1 week. But I have to say that if they're at 80, 90 and they're doing well and it's all good, depending on the case, I may remove it as well. So what you want to do is that as soon as they start consuming more than 50%, so let's say 60, 70%, 75% orally, so that's the beauty of the O-tube, is that you can also offer them food. Obviously, if they don't have a problem with their mouth, for example, you can also offer them food. So you offer the food, they eat a little bit, you top up with the feeding tube. They eat a little bit, you top up with the feeding tube. At some point, hopefully, if they feel better, they're going to eat more and more when you offer it to them. If they reach 3/4 of their RER, perhaps you can just stop using the feeding tube and see over 24 hours if they increase even more their RER consumption. And if they eat, let's say 90, 100% of their RER orally for a week, and they have a stable body weight, so they have stopped losing weight, then you can remove it. I know that some owners are just obsessed about removing this feeding tube, and they would call you or email you every day being like, yeah, he's eating, so can we remove it? Can we remove it? And I always say, yes, we can remove it when they eat well for 1 week. We don't want to remove it the first day they eat well, because how many times would it happen that you do this and then the following day actually is not eating well again, and then you're stuck because you need to re-anesthetize them? So no, we want 1 week of eating well. It doesn't matter if they don't use the feeding tube, forget about it. We'll remove it in 1 week. Some other owners are actually obsessed about keeping the feeding tube in. That's mainly in cats that are impossible to have tablets. And in this case, then it's a case by case about when you're going to remove it. But I have few owners that really felt like reassured by the fact that they had this feeding tube. Okay, so take-home messages. We're almost at the end of the lecture. I hope you're still engaged there, and that you've learned some things that you can apply to your patients soon. Take-home messages are that malnutrition is highly prevalent. So as we've discussed, it is really common. And I assume it is really common in all of our practices. We're all guilty of sometimes maybe overlooking nutrition. It negatively impacts our patients' outcome. There is no discussion about that. We know it now. There is no more excuse. We know that if they don't receive enough food, they have a worse outcome. So the gold standard care is to implement a proactive and systematic approach. So it's probably having a chat with people that are in the ward, the nurses, the other vets, about how are we going to monitor these patients and what are we going to do when we detect that they are undernourished. And that includes assisted enteral feeding. That's really a key element for these patients to provide nutrition. So by the end of this lecture, I would hope that I've achieved a paradigm shift, and that instead of thinking they will eat when they feel better, you will now think they will feel better when they eat. Thank you very much for your attention. I will be very happy to take any question you may have now. Thank you.
Thank you, Florence. That was really interesting, and I'm sure there'll be lots of questions. So feel free to put it in the chat box or the question and answer box. I'll be monitoring both. I've also shared the link to the WSAVA feeding guidelines and the 2
Thanks.
ISFM videos. One question I had, just to clarify, would you recommend radiographs irrelevant if it's an O tube or a nasoesophageal or nasogastric tube? Do you recommend radiographs for all of those when placing?
Yes, for all of them, because for all of them there is the same risk, which is ending up in the trachea, or there are also case reports where they end up in the mediastinum actually. So with all of them, you have to take radiograph. It can end up in many weird places, and also sometimes it can loop and you don't see it, and that's also not good. So anytime there is a tube, there must be 2 radiographs. Yeah.
Fantastic, that's really helpful. And when would you decide between a nasogastric versus a nasoesophageal tube?
Yes, so that's interesting, because some people would answer different things. I believe that in the States, they quite like their nasogastric tube, because what they like to do is to check how much, and ECC specialists, they love doing this, they like to actually suck out whatever is in the stomach to measure if there was anything left or not. Personally, I find that by putting a nasogastric tube, it sort of inflames a little bit the sphincter between the esophagus and the stomach, and therefore it can increase the risk of regurgitation or vomiting. So I would say never or almost never place nasogastric tube. So nasoesophageal tube is most of the time the correct answer. The only exception is in very, very young puppies or very, very young kittens. They do better if it goes directly in the stomach. But otherwise, esophageal is probably the best, I would say.
And if you had a vet that wasn't very confident placing tubes and their preference was to kind of start with a nasoesophageal rather than go straight to esophagostomy, I suppose that would be better than them not having any nutrition at all in that situation.
Yes, 100%. So as you probably understood, I love O tubes, but I also know that I was lucky to have all the staff and everyone around to train me to do this. And it may be that it's not that easy, or that you haven't been trained. So I hope that the video actually help with that, because they're really explained step by step. But 100%, some food is better than no food. And the same with bland diet. I was quite strong on the fact that we should avoid them. But obviously, if you can't place any tube because the owners can't afford it and the dog only wants to eat white fish, that's totally fine. We always need to be pragmatic. But yes, NO tube is better than nothing, and probably O tube is better than NO tube.
Fantastic. That's really helpful. And if these patients are really nauseous and people are worried about them placing a tube and then them just bringing them back up again, would you start any medication prior?
Yeah, so usually for vomiting, I would really try with the medication to stop the vomiting over perhaps 12 hours, maybe 24 hours max. So I would use maropitant to start with. If maropitant is not enough, you can use ondansetron on top of it. And if that's not enough, you can use a metoclopramide CRI. So we really have medication that are strong enough now to really try and stop this vomiting. I'm not talking about the dog that has an obstruction and then needs to go for surgery, of course. So don't do this on them, just go to surgery. But otherwise, use drugs. But what we also know is that if you remember about the article on the puppies with parvovirosis, if you wait until you've controlled the vomiting, then actually you worsen, you make their prognosis worse. So I don't really mind actually placing a feeding tube and starting a little bit of feeding, even if the patient has a bit of vomiting or regurgitation, because just the fact of having food in the stomach is going to stimulate the GI motility and may actually help you control the vomiting and regurgitation. So try to, even if you just give 5 milliliters of food in a dog like that, place the tube and start very slowly and medicate for the nausea, but don't let really nausea stop you for more than, I would say, 12 or max 24 hours.
That's a really good tool, because I think sometimes you say, oh, I can't place that because it's vomiting. So that that's really good to know. There's no more questions currently on ours. If anyone has any questions, then please do submit it. But otherwise, in the meantime, thank you everyone for coming along. We really appreciate you joining. Florence is joined the VVS team as our internal medicine specialist. So if you would like to discuss any cases with Florence, then you can get in touch with her on our website, www.vvs.vet, and she'll be really happy to arrange an advice call to discuss your cases. And it's great to have that kind of nutrition interest and experience as well, because I think there's a huge amount that would be valuable. And if there's any other nutrition topics that you'd like to know that maybe Florence could cover, then do put them in the chat box, because that's another really interesting thing, because I know it's certainly an area that people like to know more about. So do let us know if there's any other topics, but I think that's probably everything. There's no more questions. So thank you so much for a really interesting webinar. Hopefully you've taken some really important points. And if you ever would like to talk through, esophagostomy tubes and nasoesophageal tubes, then get in touch with us. We were happy to advise. So thank you everyone for coming along, and we hope to work with you soon.